We're excited to welcome you to today's FLAIR Expert Roundtable event, discussing best practices in building digital health companies and identifying product market fit. We'll be spending time with some of the most exciting and renowned entrepreneurs in the digital health space. We'll be discussing how they conceptualize billion-dollar ideas, how they use the process to identify product market fit in an industry that's known for long feedback loop, and how they build a continuous improvement process to perfect their products and services. Today, we're very fortunate to be joined by 6 amazing entrepreneurs, leaders, and executives. Dr. Ali Parsa, CEO of Babylon Health, Glenn Tallman, Executive Chairman and CEO of Transcarent. Glenn was previously the Executive Chairman and CEO of Livongo Health. Kyle Armbruster, CEO of Signify Health. Kyle recently took Signify public, and he was previously the SVP and Chief Product Officer at Athena Health. Caitlin Donovan, Global Head of Uber Health. She was previously the COO at Circulation. Gina Kim, Chief Product Officer at Cohere Health. Gina was previously a product executive at Haven. Kit Dobbins, co-founder at Kayaba Care. Kit is also a co-founder at TrialSpark, a recently minted unicorn clinical trial technology platform company. We'll be structuring the discussion in the next hour into 2 parts. Part 1, we'll start with 3 one-on-one fireside chats with Ali, Glenn, and Kyle. Part 2, for the last 20 to 25 minutes, we'll have Caitlin, Gina, and Kit joining me for a panel discussion and share their personal experiences. So without further ado, I'm going to hand it off to Michael Greeley to kick us off with a one-on-one fireside chat with Ali.
Thank you, Ian. And Ali, great to see you, my good friend, as always. Thank you for giving us a few minutes of your time. We couldn't have thought of anybody better to start this discussion. Ali is simply a brilliant product strategist and has had actually a remarkable career. And I thought, Ali, maybe just to set some context, share a little bit about your personal journey. You actually started in finance, so have come to healthcare and a little bit of an indirect route, but love to hear a little bit about that.
Thank you, Michael. Incredibly cute to have me. Yes, you're right. I started as a financier, and the last job I did was at Goldman Sachs, where I was an M&A banker. But more importantly than that is I was born in a middle class to-do family with a very loving family. And then because of the Iranian Revolution, I became a refugee. And I had to walk all the way back to England at the age of 16 on my own. And what I found, Michael, and that shaped me, and I hope a lot of people in this audience think the same way. What I found, it didn't really matter when I was young and I'm older now, or if I was a native and then I became an immigrant, or if I was rich enough, then I became poor and now I'm rich enough. What I saw was that people everywhere have the same needs, the same desires. They just have different opportunities. And if you and I can do something to equalize that opportunity curve, that's what really matters.
Yeah.
So I think what matters about what I learned in life is so much more that than it is anything else.
And so take us to that magic moment when you had the inspiration for Babylon. What were you seeing in the market? How did you think you could craft a solution to address those needs?
So I built a chain of hospitals. Today's the UK's largest chain of hospitals, the Circle Group, actually was just acquired by Centene. I think it was the last thing Jesse did before he left Centene for $1 billion and something dollars. But what I discovered was that we were solving the wrong problem, right? In average, you go to a hospital once every 20 years in your life, and if you're unlucky, a lot in the last 2 years of your life. And we said, can you do with healthcare what Google did with information? Can you make it accessible, affordable, and put it in the hands of every human being on earth? And not do so for a very simple thing, like a telemedicine or urgent care or a one-off silo, but do so across the entire spectrum of healthcare for every touch point that you need in order to fundamentally change, re-engineer the entire process across the continuum of healthcare. We started with that in UK. We were told it can never be done, but we were lucky to do that in a primary care in UK, which has a very special role in UK because you cannot do a tiny bit. You have to do the entire spectrum. You're responsible for chronic conditions, mental health. Everything is the responsibility of the primary care. You have to send somebody to a hospital, bring them back, help them to recover. So that allowed us not to build a one-off siloed platform, but an end-to-end platform. We then took it to one of the poorest countries in the world. We didn't go to Germany. We didn't go to France. We went to Rwanda and say, can you deliver that to some of the most challenged communities economically? And of course, one of the most delightful things that happened to Babylon was when last year President Kagame became the first in Africa to make primary care universally available for free to his entire nation on the back of what we're doing. And then, of course, today we are in the United States. But in the US, again, we didn't start with the rich communities, with the commercial community. We started with the Medicaid community, and we started with one of the most challenging in the boot hills of Missouri, in some of the most financially challenged rural communities. Yeah. And the results on those have been exceptional. So we're growing really fast in the United States. But I don't think it's so much about what you do, how you do. This question of why you do what we do, all of us in healthcare, really matters to all of us.
And why we think this conversation is so important, Ali, is product market fit is such a challenge for all of these healthcare tech companies. You're tackling that on a global scale. Are you seeing enough commonality around those issues that, putting aside economic conditions, social conditions, you can solve that similar problem across multiple geographies in parallel?
I always say, I had this debate once with a leader of a medical association of a country. And they were talking to me about how utterly local healthcare is. And that's many of doctors, you even get licensed in the United States per state, let alone for the whole country. And I said something that he thought was highly controversial, but I still stand by it. Unless you're deeply racist, you must believe that human beings are the same everywhere in the world, right? So our healthcare, our biology is the same. Now, that doesn't mean the model that we have to deliver in every country is the same. I think about 85% of what we do is universal, but that 15% we need to localize and adapt and really matters. Look, a human being shares 83% of his DNA with a cockroach. It's that 17% that makes all the difference. So I'm not one to deny the importance of localization, but I think this idea that healthcare should be done in a silo is wrong. And look, Michael, you know this because you're one of the best investors I know in healthcare. You know this very well. It is wrong when you digitize any industry to try and take the old physical format and just basically copy it digitally. Google didn't go and say, how do I digitally enable libraries? It went in and said, how do I reinvent what it is that people want to achieve, which is get to information. And I think that's why we should do in our products. It shouldn't be what happens in physical world. We should almost forget about that. We should say, what is the best route to achieve the goal that people touch the physical world for?
Yeah. And Ali, to be a little tactical, how are you capturing that voice of the customer and iterating that in the product cycle? How have you organized your team? How is that market feedback getting iterated?
So every interaction you have with us, you rate it. Everything that is rated low will try and reach you to find what it is that went wrong and then try to fix that. And it's quite a lot. I'll give you an example. One of the things we saw in Rwanda was that our delivery was skewed often towards men. And we were asking ourselves, not a lot, but a little bit more than normal. It wasn't exactly 50-50. So we figured out and the problem, of course, is often the phone is registered to the man. And the model was you have to be registered to the phone to be able to do the consultation. So we worked with the government of Rwanda to do something very simple, which is to allow you to consult with us and we get your national identity rather than your phone identity to verify you. That single thing, Michael, increased our female consultation by 60%.
Yeah.
Right. So I don't think people who say, I need to be a genius to figure out what the market wants. You don't need to be a genius. You don't need a brain. You need ears and eyes. You need to watch and see what it is that your people are telling you should do.
And so how do you arbitrate the tension between product management and engineering? Who has a supreme voice in that dialogue that you have on your team?
So we don't have, our teams are all objective orientated. So we don't have an engineering team or a product team. We have squads that are designed around a single objective, right? And therefore they work hopefully as a team, as opposed to I go as a product person, figure out what needs to be done, and then do this. And then one of the things we do is we film and we go live and spend a lot of time with our members. So when we went in Missouri, we spend a lot of time with the people that say you cannot reach, or in California or in New York, with people they said you cannot reach. And what we found out is that these people definitely want to be reached, right? Yeah. It's the pain points that they had, right? Yes. And then we make our engineers and our product people watch those films so they can live with that community. But I think you're touching on something really important. One of the reasons Silicon Valley, in my view, has failed to create solutions for healthcare is because they do so on what is the right solution in their mind, as opposed to what it is that people need.
Yes, that's what I was trying to get. I've heard you say that. And in full disclosure, we sit on a board together. You're a brilliant product visionary. And so I was trying to get at that set of insights. Again, we think one of the greatest risks for many of our company is product market fit. And the rapid cycle time. How do you take what the market is saying and incorporate that into your product design strategy?
I think you just touched on something really important. Rapid cycle, right? Yeah. I was looking at our data in the last couple of weeks. We, Facebook, and two other companies were the fastest iteration of data of product. So we iterate our product about 4 to 5 times a week. So if you go onto the App Store, you see a new product every other day almost, right? And it takes and we're in a regulated environment. There's no one else in that elite group of people who could come up with a new product every few days who are in regulated. Facebook is not regulated, as you and I know. Unfortunately, in my view, they should be, but they're not. But I just think that often we forget that it is about that core capability to allow you to do really fast adjustment to any country. We launched our product in 11 countries in Southeast Asia, in 15 different languages, all approved by the local regulators. And that's what the piece that took longest, right? In less than 1 year. And that tells
extraordinary. You. Extraordinary. Ali, I could talk for another hour with you. Glenn Tolman is about to push us off the stage. I'm going to welcome Bill Geary, my partner, on the stage with Glenn. And I hope you appreciate, Ali, that my backdrop looks just like your office in London.
That your backdrop does look just like my office in London, but my backdrop right now is rather different. I'll show you. I'm in the west coast of Canada, and it can't be any more beautiful, but it's the same rain as you have. And I will yield the floor to Glenn any day of the week. Because Glenn is one of
I just learned so much listening to Ali, but I hate to follow him. Why'd you have to put me after him? Gosh, you know?
My friend, I'm a
only downhill from here. Ali, thank you so much. Bill, over to you.
Excellent. Thank you, Michael. Listen, the good news is Ali said, Glenn, you just don't have to be that smart in order to pull this off. So maybe there's hope for all of us. Glenn, great to see you. Huge congrats to you on everything you've done professionally in your career. It's just astounding. You started, ran, then chaired arguably the most notable company in digital health in Livongo. And now you seem to be doing it again. So I want to touch on all of that. But I also really want to just drill in on this whole product market fit question. At a time when people were focused on virtual care management for diabetes, you took that and combined it with connected diagnostics, and somehow magically that's what the market was looking for. So how did you get a handle on what the market was indeed looking for? How did you get comfortable that you were on the right track? What was that moment when it all seemed to come together?
I think, playing off of what Ali just said, you have to be out with the people who actually use this. This isn't something that you can do remotely. And fortunately or unfortunately, I had a very direct experience with diabetes. My youngest son, Sam, was diagnosed when he was 8 years old. And I saw firsthand how hard we made it for people with chronic conditions like diabetes to stay healthy, even if they wanted to be compliant. And so based in part on that experience, and fortunately, Sam has done very well. He's now 26, but I saw this challenge that we did. For example, if you have diabetes, you prick your finger and you check your blood sugar multiple times a day. The strips are very expensive. So occasionally we would run low and we would call up our plan and they would say, we can send you needles now, but we can't send you strips. But if it's an emergency, go to the ER. I just shook my head and I said, that's the worst advice I've ever heard. So at Livongo, not only did we start with the member, the person, the individual in mind, but we always put them first. And then about a third of our people, including our president, Dr. Jennifer Schneider, she lived with and lives with type 1 diabetes. So we knew intuitively what it feels like. And we built that into the responsiveness. And being connected meant that 24/7, we were with our members all the time. We understood what they needed. We could monitor what they were doing, provide suggestions, very personalized, and we made strips free. So it really was about that fit and living the life that your user lives. And that's really what was key.
Yeah, no, it's fascinating. Certainly your model and many models are B2B to C, and there's just notoriously long feedback loops for the B in the middle. And certainly it's an industry that's not very conducive to testing and learning. And at the same time, you've got to satisfy the consumer. And of course, that's what you were just talking about now. So if you go to the enterprises in the middle, how do you get them to accelerate what otherwise can be an extraordinarily long and maybe even company killing time period?
You've hit on 2 points, and I want to spend a moment on the first because it's really important. B2B to C is part of the problem. So at Livongo, we were talking directly with the person using our product. And the beauty of so many products like Amazon, how do they know what books I want to read? Because they ask and they see what I buy and they have that closed feedback loop. So we had a feedback loop. If we would make a suggestion to our user, because we were connected, we could see whether our member did what we asked. We said, check again in 20 minutes. We would know if they did. And so consequently, we did more of what worked and less of what didn't. And that loop. Now, the problem was when we went through third-party navigators or aggregators, what happened was our ability to recruit, to activate people, and their retention dropped off significantly because someone was in the middle. If you go through a payer, and look, all of us, if we say our payer provides telehealth, but we have to dial the payer first, utilization drops way down. But we had a direct, and we insisted on a direct relationship with our member. So that's part one. Part two is interesting, and that is, how do you sell? First of all, we believe in all of our businesses that large self-insured employers are going to drive change because they have the most at stake. They see both the experience and they pay the bills. And part of transparent is the realization that the two most important words in healthcare today are, number one, experience. We've created a terrible experience for most of us, our sons, our daughters, our mothers, our fathers, and all of us. It's a bad experience in healthcare. So how do we change that experience? But the second piece is alignment. And if you remember when Haven was launched, what Jeff Bezos said was, we will never be aligned with the payers because every time we spend more as an employer, they make more. So why would they ever want to really reduce the price of healthcare? And they haven't for 20 years. So what we've done at Transparent is said we're going to create an experience that people love, not just but love, like they did at Livongo, that we can prove that the care is better, and last but not least, the cost less. And we're going to share upfront that savings with all of the people who pay for it. And that's all of us, because we all pay co-pays and co-insurance, and the people who employ us. So we changed that model. We're 100% at risk. And so the only way we win is if the employer wins and if you win. And that's a very different model. In our current system, payers and PBMs win even when we don't. And we don't know what the quality is. Everybody at Transparent will be assured, just like they were at Livongo. Because when people talk to me about quality, when they talk to Dr. Schneider or our CTO, whose dad had diabetes, and they talked about quality, it was like, this is my son, this is me, this is my father, my mother. The idea of quality was so core to what we did. And that's the same thing. When I left there, people said, Glenn, can you do for what you did at Livongo for the rest of healthcare? And that's really what I wanted to go on vacation. But Lee Shapiro, who you know well, Lee said, I don't want you hanging around here. Go get a job. And I had to buy a company to do that. So there we go.
It's awesome. And I'm a huge believer in novel risk-bearing models. And obviously you're on that path with Transcarent, but maybe just to operationalize product market fit for a second. What are those leading and current indicators that you track to ensure that you're on top of and driving product market fit? So maybe describe to the people who have joined us today and are listening, and those entrepreneurs and founders, what does your dashboard look like? And what are those specific metrics that you're tracking and that you obsess about?
First of all, you have to say for who. So if it's for the end user, for our members, that's one set. If it's for the people who are actually buying from us, that's a different set. So for our members, first and foremost, it's experience. And that is, all of us have been spoiled, and I put that in quotes, by the experience that we saw even during the pandemic. We love the fact that things could get delivered. We love that we didn't have to, get in a car and go for certain medical care, that we could use telehealth and the like. And so having seen all of that, now we've changed our standards. And that was already happening in so many industries. We wanted things to be easier and better, except in healthcare. And in healthcare, if you survey people, what they tell you is today, healthcare is more confusing, more complex, and more costly than ever before. That's what users tell you. And if you look at the ratings of payers and of healthcare organizations, they're embarrassingly low. And so first and foremost, how do we create a great experience? Let me give you one example. We really got with people and said, what do you want? They said, when I have a healthcare question, I want an answer in 60 seconds. That was our standard at Livongo. People loved it, 24 hours a day. But they also said something different. I've done too much of what we're doing today, too much Zoom, too much of this. When I want, in the middle of the night, I have a question, I don't want to see somebody on Zoom. I don't want to have to get dressed. I just want to text somebody and I want the answer back and I want a record of it. I want it to be a physician. I want it in 60 seconds. Can you do that? And that's what we do. So they said, I don't want any more bills. So we said, let's eliminate billing. Yes, that's true, eliminate billing. How many of the listeners today have a bill that said, this is not a bill? Did you ever get one of those? And imagine somebody decided to print on something rather than fixing it to say, tell people what it is. Here's what it's not. It's also not a gorilla. They could tell us that too, but that doesn't help us solve the problem. So the issue is they want a better experience that they can do three things. They want to know what are their options, unbiased information. They want trusted guidance. What should I do? Not send me to a place where you make more money. Where's the best place to go? Just like it was your son or daughter. And last but not least, can you get me in? Because Bill, I know what you do. If something happens, you call a friend, a doctor, whoever, and you say, hey, what are my options here? What would you suggest I do? And then the last thing you ask, can you get me in? All of us do the same thing. And so we're opening that up. So our great clients like Target, whether you're the CEO or the janitor, if you need back surgery, we're paying to fly you to some of the best centers of excellence in the country to consult with an expert who will tell you that in probably a third of the cases, you shouldn't have the surgery because we do too many surgeries. And in the other 2/3, you're going to get the same treatment the CEO got with no bill, no copay, because you need it. And that's the new model of healthcare that we're creating. Now, what do employers want? Believe it or not, employers want quality care for their people. They really do. And they just want to know that they're getting a good deal. It doesn't have to be the lowest cost. But what they're getting today is a bad experience, no sense of quality, and paying costs that every year go up and up. So that's really what we see as the fit. We monitor that constantly. They also don't like to pay for things that people don't use. So the whole idea of navigators pay for all our people to use it, even though only some do. Remember, at Livongo, you only paid if somebody used it and if they kept using it. And so it would be like going to a restaurant and they say, Bill, I want you to pay even if you don't come here. And even if you came in and the meal wasn't good, I still want you to keep paying me each month. You'd be like, that's crazy. That's our healthcare system. And we're going to change it. And that's what we're doing.
Awesome. Glenn, super impressive, really insightful. Fantastic having you with us. I just can't thank you enough. And thanks, obviously, for our friendship, too. Appreciate you being with us. And now I'm excited.
Thanks for what you're doing and driving all the innovation you all drive at Flair. And we appreciate the partnership.
That's awesome. Thanks a lot, Glenn. Thanks for being with us. Ian, I'm excited to turn it over back to you. Thanks so much.
Thank you so much, Bill. And thank you, Glenn. And thank you so much. It's my honor and pleasure to welcome Kyle to the stage. And Kyle, really appreciate you for taking the time to join us. Could you share with our audience your journey from Athena Health to Signify, especially as someone who's as a chief product officer throughout your career? What has that transition been like?
Yeah, absolutely. And thanks, Ian. Glad to be here. And thank you to the Flair team. I have a ton of respect for you guys. And I've known many of you for a long time. So appreciate you guys putting this on. Yeah, I started off in Athena, focused on corporate development and helping to take the organization from really being focused on rev cycle. And we'd started moving into the clinical space and starting to think more about the continuum of care and how we could really expand our technology footprint. So built out a bunch of APIs while we were there, connected over 100 partners through the More Disruption Please program. And it was an awesome opportunity to really learn a lot about healthcare. What I would say at the end, though, I really wanted to get closer to the home, move away from fee-for-service, more into value-based care, and then also expand into a more holistic care model where instead of cajoling doctors and clinicians and others to do things through software, we actually would have, as a part of the business model, a labor force. And so that was what the genesis was, what helped create Signify, those three desires of mine. And I've been on at Signify for 4 years now. And yeah, we're the largest company in the country that sends doctors and nurses doing a battery of different complex work inside individuals' homes. So we'll be in just shy of 2 million homes this year. We were in about 300,000 when I started a few years ago. And it's been a great ride. So we do all of the work in the home and then also have a very large episode of care business where we're helping to go out, give guaranteed savings to a risk-bearing entity, and then doing shared savings contracts downstream with provider groups. We bring all of that network of 9,000 doctors and nurses and our over 600 social workers to help reduce readmissions, shorten length of stay, and to make sure that folks are getting better outcomes. And yeah, it was a great journey starting off, I would say, in a tech-enabled service business, which Athena very much was, and bringing a lot of what I gained from there and a lot of my team, frankly, over to Signify, and they've been a big part of the story.
That's phenomenal, Kyle. I have to say, as someone who used to be in the industry on the home-based care side, what you and the Signify team have done, it's truly legendary and just impressive through and through. And maybe going back to some of the early days of Signify, as you're looking at some of the assets that came under Signify, how did you determine they truly had the product market fit that's worthwhile for you to bring under the Signify umbrella? And also would love to hear, how did you put these assets together and truly determine that's what the customers are looking for? These are the assets and the services.
Yeah, absolutely. I would say first, there's extreme conviction from myself, my team, and our capital sponsors that fee-for-service was on the way out the door. And we knew that Medicare Advantage, Managed Medicaid were two predominant models that we wanted to map into. And I, through watching the growth of facilities gobbling up other facilities, saw that work RVUs and productivity was getting cut, right? And so I knew there was a absolute need for a more differentiated service that would bring healthcare to people in a more convenient and accessible way. And so we started off by going out and finding businesses that had national scale. So we merged in two competitors immediately and created the core of Signify that were doing in-home services. As I mentioned, they were seeing about 300,000 folks in their homes across the country. We've expanded that dramatically. And so we took those two core businesses that were in doing hour-long evaluations of predominantly Medicare Advantage members. We've expanded that into Medicaid. We've expanded that into commercial populations. We can do that virtually now. And then we've also moved very heavily into the STARS HEDIS quality space. We bring over 12 connected devices into the home, doing diagnostic and preventative services. And we've now very deeply mapped into really taking on conditions when we find them and helping to make sure that we're managing those conditions, both on the back end by supporting that episodic payment construct, but also using our clinicians and social workers to provide a holistic care model to reduce cost while always driving better outcomes for the lives that we touch. And so as we continue to scale that business, we wanted to find an asset that helped round out the social components. We found TAV Health, and our clients were asking us, they're like, look, you're in these homes, you're seeing all these social conditions. We need you to help break down the barriers between the community organizations with a skilled social worker team and drive out some of these social comorbidities. And so it's been one of the fastest growing parts of our business, and something that I would say we've had pretty universal adoption across the majority of our customer base. So that's been a big success story. And so that was moving from just clinical to a more holistic model. And then finally, we wanted to participate in risk, but we didn't want to compete with our clients like Humana and United. And we work with a lot of the startup payviders out there too, many of whom have just gone public. And so we found this episode construct. And the beauty of episodes, Ian, is that it can sit on top of any payment regime. So it sits on, and our largest client is CMS via the Medicare fee-for-service book. And it brings a value-based care-like construct for a 90-day window. And our hypothesis was, if we took all of that service density we have in every county of the United States and applied them to folks inside those episodes, activating the home as a place for them to recover, not just the inpatient rehab facility, not just the skilled nursing facility, that they could have a better experience, that they could recover more quickly, and then we could have more shared savings to share with our provider partners. And I'm happy to say that's been a big success. We had a very high positive shared savings rate across our entire base, even in the peak of the pandemic when skilled nursing facilities were shutting down and nobody could get properly triaged to go get a procedure. And yeah, that was the genesis of really what we pulled together. And I would say that the key thing that we did to make those acquisitions successful was not start with a spreadsheet, but start with the outcomes of the patient first, and then the people that we were bringing along in the team. And I feel like a lot of folks get M&A integration wrong because they are all focused on the synergies. A lot of those things come if you focus on the people and the output and the value that you're actually trying to create when you pull the business together.
That's amazing. The learning people first, and we also hear throughout the day. And maybe Kyle, just to double click into it, so the process you have developed, it sounds like you perfected that feedback loop to hear the needs from your customer, your patients, and the people you work with in the community. How do you, I'm sure since the onset of COVID, there's a lot of needs to bring care to the home. How do you will be inundated with all the requests of different services? How do you work with your team, prioritize these potential services requests, and how do you go about to really enable it?
Yeah, it's a great question. Yeah, I'll give you a good example. Beginning of the pandemic, we were inundated with requests to do COVID tests and to test in facilities, test in the home. And we did it for a little bit, and we worked with the federal government. We did a ton of them, actually. But midway through the summer, I made the decision to pull back on that completely and focus on our core and what we were really good at, which is connecting with people, helping to drive better outcomes. And I viewed that as something that was going to increasingly get commoditized, which it has, right? You can get a COVID test over the counter now at this point, and that's a great thing, right? That's what we needed to happen. I think, Ian, it's really important to stay true to the business case and to pilot things with clients and to measure constantly the value that you're creating as a result of the services. And I do not believe in disconnected business models that don't get you paid for actually doing work, right? And a lot of the payer clients we work with are extremely fed up with PMPM models, right? They call them PMPM piranhas, and they feel like everybody's taking a PMPM and everyone's claiming attribution and claiming that they did everything to prevent all these various things from folks. And I think you've got to be in the risk stream and you've got to sign up for real results. And the only way to do that is to have real discipline with your finance, product, and R&D teams to ensure that you're really driving positive outcomes, whether those are financial or clinical, whatever they might be, for the organizations that you're working with.
That's great. Thank you so much, Kyle. I, as someone who used to be in the industry, what you just shared are many of the things other innovators in the industry must internalize and to build a phenomenal product. Maybe as we could go on for like hours, and I would love to, I'm sure our audience would love that as well. Maybe before we thank you for spending the time with us, if you have any advice to some of the entrepreneurs really moving towards the valley, what would be a couple of the metrics you would be looking at to identify whether or not your services truly hit that product market fit? Any guidance would be greatly appreciated.
Yeah, absolutely. It's a good question. I think number one, and I don't think people do it enough, is to get out and actually talk to customers and listen to them. Like, they will clearly articulate their problems, and where I think great entrepreneurs succeed is they help identify ways to measure and manage those problems. A big problem with the plans right now, many of them, they can't measure the downstream impact of a lot of the upstream work, right? And they can't connect the claims and all the payments and the data to fulfill that. And so I'm always reluctant when folks come in with a pure technology solution or think that it's healthcare is like other industries where you can just throw some SaaS model at it. Services are super important in healthcare. You're touching people's lives. It is a convoluted mess of interop and different service providers doing these PMPM models. And to me, more than anything, you've got to measure patient outcomes at the end of the day, because I deeply believe lower cost is usually correlated with higher care, or better care rather, and focusing on that better care element and then backing into the lower cost piece. That's how you build relationships and get people's attention, I think.
Thank you so much, Kyle. Truly insightful. And thank you so much for your guidance and advice and sharing your experience. We just want to thank you once again.
Great.
To our audience. Oh, thank you. Great. Thank you, Kyle. And we're looking forward to seeing and chatting with you again in the very near future. Thanks once again. To the audience, we're now transitioning to our panel discussion. And so I have the privilege and honor to welcome some of our friends. So Caitlin, Gina, and Kit to joining me for the next 20-25 minutes of discussion. Thank you all. So with this panel discussion, maybe I'll start off by asking you a few questions, and then we'll switch into more of a roundtable discussion. Why don't I start with you, Kit? So first, congrats on TrialSpark. I know that it's newly minted as the unicorn. I remember the early days of TrialSpark. I remember speaking with you and never get the true origin story on how you and Ben landed on the idea and how you guys knew this is the right idea. We'd love to have you maybe spend a minute just to share with our audience at that very early stage. How did you conceptualize the idea and how did you know it was the right one?
Thanks, Ian. I really appreciate that. And the continued growth of TrialSpark is really a testament to my awesome co-founders, Ben and Lin Hao, and the team there. And as it relates to how we came up with the idea, we first started with the problem, which was that you have amazing researchers with terrible websites. You have these folks, vaccine researchers, geneticists, et cetera. And Ben, my co-founder, was a scientist himself and felt that problem acutely. The second step was trying to understand who we were solving the problem for. So we had the option of health systems, hospitals, pharma companies, academics. And we started with academics because we knew we could get to them. We had academic emails ourselves. We knew they had budgets assigned to their labs, and we knew they had credit cards so they could transact quickly. And then the third step was to sell our idea and talk to customers, like Kyle said. So we spent an entire summer selling websites to these scientists, and we didn't sell a single website. Talked to 60 to 80 scientists. But what we did here was that scientists actually had their websites to try and broadcast their work to prospective research participants. So we pivoted over time and then started selling websites for research studies where we would drive participants to the website. And I'll never forget the first sale. I was talking to a researcher from Johns Hopkins, and she asked me how much it cost. And I hadn't thought that far ahead. And I just said $15 for the year. But we knew that once we had a paying customer, that we had something that she had wanted, and she quickly started referring people and grew that into a multi-million-dollar business just alone on that premise. And that's how I'd outline it. You can really start simple.
Got it. Thank you, Kit. And maybe let me ask Caitlin the question. So I remember meeting you, Caitlin, and also Robin during some of the early days. Like circulation is such a beautiful idea. And we were thinking about brainstorming some potential use cases when I was on the industry side. How did you and the team identify a handful of true killer use cases during those early days? And of course, I'd love to hear how that also transpire and also translate into what you're doing now on a day-to-day basis.
Fantastic, fantastic. And again, thank you so much for having me. And Ian, it's so nice to see you again virtually in person. Like Ian said, so right now I'm the global head of health at Uber, but formerly was the COO at a company called Circulation that really was a specialty benefit manager for non-emergency medical transportation. I was very lucky to join a co-founding team of Robin Heffernan, Jared Hawkins, and John Brownstein, who had identified, like Kit just said, that there was an opportunity and a problem to solve, which is, I think, the right combination. So they found the opportunity by experimenting with how to deliver flu shots on demand, actually. And you needed a way to solve the logistics. You needed a way to get patients to healthcare and healthcare to patients. And that's where the idea for Circulation was born. The next step was really thinking about how to scale that opportunity, where they found that the adherence to folks getting their flu shots was much better when the logistics was made easier. And the way that we all thought about that was, how do you find a reimbursement structure that's already in place that isn't working well, so that you've already solved for the payment portion? Because it's so hard to convince health systems, insurance companies, et cetera, to pay for something else. So the non-emergency medical transportation industry, it's a covered Medicaid benefit. It's about a $6 billion benefit, and was a great entry point, one, because it was an existing benefit, and two, because it really needed disruption. The member experience of that benefit is truly awful. The number of complaints that you get relative to the size of the benefit is very material. So just by offering that tracking, that GPS location of where a member is, that allows that call center to proactively respond to issues, made a huge difference. And once that happened, you then found ancillary use cases, right? Where health systems were sick of calling the brokers who'd been the incumbents in the industry, were willing to pay out of pocket for things that weren't covered because they saw the ROI. And I think that's really the strategy, right? Is meet an industry where they are, solve a specific problem, and then you can work your way through the net new interesting things.
That's great. Thank you so much, Caitlin. And we'll for sure be going deep into it during the roundtable discussion. And maybe Gina, let me ask you, as you have seen being a product leader across many organizations, from early stage startup to very large companies, what were some of the ways you truly use to measure product market fit? And can you share with us some of the techniques or tactics you use to truly help identify product market fit so quickly?
Yeah, absolutely. And thank you for having me. It's really an honor to be on panel with such great leaders. So for me, product market fit, I think similar to what other folks have said, it's really three things. So one is, do you have a problem that's worth solving and a good way to solve it? And then will someone pay you to solve that for them? And then I also think about a second order problem, which is, how do you actually get stood up? Because in healthcare, change is hard, and it's really hard to drive people to make a switch. So in terms of the problem we're solving, some of the techniques and the tactics that I've used in the past. So the first is really to invest a lot in research and design. And I think that's come up before, but if you don't know the problem you're solving and you're not deep in there living every day the way that Glenn talked about Livongo, but you really don't understand the true pain points that you have. So getting into the field, shadowing, understanding, and then equally, I would agree with Kyle that taking on a service is one of the best ways to learn. If you actually are on point for delivery, you learn all of the dirty little tricks people have, and then you can really understand where product or technology are able to help with those problems. And as an example, at Cohere right now, we're trying to get stakeholders to collaborate on getting patients to the right care at the part of the patient journey. So ultimately, we're decreasing costs in the systems. And we're starting with prior auth. And we are a product and tech company, but we have a services arm, and that services arm is a learning lab for us. And so we can understand how decisions are actually made. What are the operational processes that you actually need to think about? And so as they operate at scale, we scale with them. And that's been a huge ability to control our learning and actually get into the guts of true problems. And then the other tactic I would have there is really to test. And it's really easy, I think, as a product and engineering company to try to dive into coding things and making prototypes. But if you actually take that step back, I really try to encourage my teams to try to test without code. What is the smallest thing that you can prove to yourself? Is it that you're trying to get a patient to engage? Is it that you're trying to get a clinician to change a step in the workflow? Because again, change is really hard because people have habits. And a lot of people jump to EMR integration or, hey, let's build an app. But the reality is if someone's not going to answer a text, they're not going to download an app. So what is that thing that you can test? And when I was at Kairos, for example, we found a pain point that a lot of folks who are scheduling on the enterprise side for health systems had, which was they couldn't keep track of all of the different data around provider Dr. X, like only wants to be scheduled on a Friday afternoon for these types of patients and not for these types of patients. And all of that was on Post-it notes. And instead of immediately jumping to an app, if you can run a test where, hey, you put some of that information in a spreadsheet and you try to make it easier for them to look it up. We were testing the hypothesis of a lookup. And I think that then can lead to, hey, now do we actually build something around this because we can actually see that folks are engaging. So that's, I think, some of the tactics. And on the payment side, I think people have covered, you just have to get out there and talk to people. Talk to as many people as you can. And if they have that problem today, are they solving it? How are they solving it? Is there an existing line item? And then can you get some feedback on if the solution that you're proposing is 10x better? Is it faster? Is it cheaper? Is it higher quality? What is that thing that you can see people's eyes light up? And then if they don't have that problem today, which I think is the case when I was at Gaslight working on cost transparency, is there some other force that is making your need a business imperative? We pay a lot of attention to regulation in healthcare because I actually think that's one of the ways that change is really driven and gets some of the activation energy overcome. And how do you actually drive the EMR adoption, for example, was one of those. Telemedicine right now due to COVID, I think you can see some of those changes where things have been stagnant, but then suddenly there's a regulatory push or a payment change or a difference in the payment model. And that pushes the potential for innovation. So I think paying attention as well to regulations in that environment is helpful.
That's great. And Gina, thank you so much. And you also just kicked off my next set of questions beautifully about how to shorten the product feedback loop. And I was actually earlier this morning talking to a product leader from one of the large health systems, and he used the analogy of asking the team, right, to build any product in healthcare. It's like steering a aircraft carrier. You need to know 18 months in advance because you just don't do things overnight. So maybe I'll ask Caitlin, and then also Kit, love you guys to also share your perspective. Like, how did you learn shorten the feedback loop in the industry that's known for long sales cycle, long implementation time, and how do you make sure that you're capturing some of the qualitative insights early on to inform you building the right product and solutions?
I actually completely agree with what Gina said. How do you test without code? We always called it, how do you lead with duct tape and follow with your tech? Maybe it's because my background is primarily in operations. I think that people view tech solutions really as a panacea to their problems, but it's not going to work if the process doesn't match it. And so working on what's the process followed by what's the tech feature that solidifies that, I think is really important. The second thing couples that with how you approach the market, leading with what you can do today and starting to have active discussions about how that applies to tomorrow. So you don't wait for the full vision to be ready to get a pilot going. I think it really shortens the sales cycle from pilot to full product.
Thanks, Caitlin. Kit, maybe can you also share with us, you're now building a company that's also selling to the health plans and health systems. What are some of the ways you guys are using to shorten that product market fit and by getting the feedback loop you want to build?
Yeah, I know Gina mentioned the services side and where that does or doesn't come in. I think one thing that services afford is usually greater interaction and consultation with the client or payer in Cohere's case. In Kayaba Care's case, greater interaction with the patient. So we send folks into the home to manage high-risk patients in underserved communities during the prenatal and postpartum period. And so we're actively testing with the patient new prototypes, new approaches, and constantly taking that feedback back to our product and eng team. And I think it's obviously a really tough time to do things in person, but to the extent that you can, we find, and I find, the feedback really rich and some of the relationships built that we can then go back to. I also find that in conveying information to health systems and payers, when we're able to demonstrate the learnings that we've developed and put together based on our work with the patients in person, that it seems to carry a little bit more weight. And so that would be one takeaway that I've had.
Thanks, Kit and Kaylin and Gina. Maybe one question, and let me go back to Gina just to get your thoughts. We all know healthcare, there are so many use cases and so large and also such a diverse set of population, right? And we have this concept of false positive. Like we see many of the startup, especially in digital health, like they may have a handful of customers, but hitting that kind of truly the scaling, because oftentimes they might be measuring to some of the metrics that may lead to false positive. How do you tell signs from true product market fit from those potential false positive signs?
Yeah, so I think of both false positives and false negatives in this sense. So I think false positive is where you think you're getting traction, but at some point there's some breakdown in terms of the buyer, the market size, your own ability to scale. So if solutions are too bespoke so that you're not able to really get your company to the next level. And so there, I think you really have to dig in and understand your customers. You may be working, let's say in our case, we work with health plans. What are really the differences between a small regional health plan and their needs versus a blue versus a national? You have to get in there and understand, if I get a buyer for one, is there going to be, how big is that market? And that, again, it comes back down to talking to a lot of people. I think there's just no substitute for getting out there in the market. And then the false negatives, actually, strange sense, find harder because it's very easy to get no's. People say, yeah, that's good, that's great. But when you're actually out there selling, the sales cycle is long. And so do you cut bait or do you not? And so for that one, I think in my mind, it's, hey, do you have the right crowd? Like in a false negative, maybe you are pitching to the wrong crowd. You don't have the right person that you're talking to who can actually drive something forward, or you have the wrong pitch. And so if the idea is actually good, you need to make sure that you are talking to the right crowd and have the right pitch. And that's where I think if you can build the relationships to get the feedback on those two things, that can help you navigate whether it's actually a bad idea or if you just have missed the mark in terms of who you're talking to.
Got it. Thank you, Gina. And maybe Kaylin or Kit, I know we're coming up on time, maybe any 10, 15-second advice on how to filter out the false positives.
Yeah, I think the key is knowing when you get a lot of custom requests, it's probably not scalable in a soundbite.
Great. And Kit, maybe last but not least, any 10-second, 15-second advice?
Yeah, I think that I couldn't agree more with Caitlin on the custom request. There's so much desire to please your customer early on, but really thinking about what that looks like and the implications of that downstream.
Great. Well, thank you, Gina, Kaylin, and Kit. Really appreciate you for joining us. I look forward to meeting all of you in person and then for continuing the discussion. I know we're coming up on time, and thank you all for joining us. Thank you to our speakers, as well as all of you audience joining us and spending the past hour.